It's on, yeah? Good. Right, so it's a great pleasure to have Dr. Giuseppe Zappala, who is not only a great clinician neurologist, is also a very good friend of mine and a good friend of us. He was the driving force behind the International School of Clinical Neuroanatomy that we thought about around 7 years ago, and then we managed to run for 5 consecutive years. We're taking a break this year. Yeah. We'll come back next year with even with more energy and ideas. So it is a great pleasure because you rarely have speakers that talk about something that they witness emerging in science. So Giuseppe Zappala was in Boston, the United States, in Boston in particular, when actually the California Verbal Learning Test was developed. He trained with Edith Kaplan, who was really the neuropsychologist behind the California Verbal Learning Test. And people has been applying this California Verbal Learning Test for many years. We're talking about more than 20 years. And he even got the original copy that was given to him, which was not digital one. It was a paper one. So he's got a great experience in the field. So not only he will talk about a very interesting aspect, which is how to assess certain functions with a neuropsychological tool, but he will also give you a bit of ideas and a flavor of what are the joys and the backdrops of doing neuropsychological work, both in clinic and for scientific purposes. So I don't take any further time away from your lecture, so thank you very much for accepting to give this talk.
Thank you, Marco. First of all, few minutes, only 1 or 2 minutes, to thank all of you to participate today here. I've been here for a week now, and I've been enjoying staying with all of you. I think it's very stimulating and very exciting what you do every day. I had the opportunity to see you probably in one of the best environment, and being able to share with you the information and feeling like a senior student together with you has been very interesting. I don't think there is never the word stop learning. Each of us will learn every day, and this week has been for me very interesting, and to learn and relearn even those topics and ideas which one has in his brain since ever. I wish I could stay with you even one more week, but not this year. Well, I try to manage that for the next years. The title, as you see, it's intriguing, it's interesting. We can touch the topic from many different areas and many different aspects. However, we should decide what to do, and we chose to go from neuropsychology to neuroanatomy, or the two disciplines which meet at some point. I cannot avoid saying and spend a few words also about my medical degree, but not because I want to tell you my story. No, this is the beliefs that I have inside myself, which always drive my life clinically and even professionally, and even in a general sense. Of course, the history taking, you have learned and you have heard this thing many times, I'm sure. The clinical history is a very, the diagnostic process is a very complicated, very thorough, very long, very stimulating, intriguing process. And you never forget. It's a stepwise recognition backwards of the history of the patient. And before we try to make any conclusions about any symptom, any deficit, any kind of problem, please make sure that you also do the best you can and try to figure out, this is not, okay, try to figure out what has been the history of that person, of that patient. You have probably heard there are easy or there are focal signs in neurology in general, but this applies to any discipline. There are symptoms which are more easily recollected and more easily associated to certain networks or certain circuits and anatomical areas. But there are also some signs, many signs, which we can define non-focal signs, very common, very frequent, and these are complaints of many patients when they come to you, if you are and when you are a clinician. And these items and these focal signs, non-focal signs, very seldom we can define them very clearly and apply our knowledge and try to associate them to a specific brain area. So in other words, they are not very easily definable or localized anywhere. And this is more interesting and more intriguing and more challenging if we do that, because according to age, our knowledge most of the times is never complete or never appropriate. The role of neuropsychology, few words again here. In the last many years, of course, there have been debates, as you know. I will just skip that. But in the past, neuropsychology has always given the opportunity to find if there is a relationship between a symptom, a deficit, a performance, and the brain area which is correlated more or less with that normal or deficient behavior. This is what neuropsychology is all about. So it's establishing in some ways which part of the brain is working or not working in general. If there is a lesion, how big, how severe is that lesion, how that can interfere with the rest of the life. Okay, basically. Very seldom, however, neuropsychology has asked the question, what can we do with that lesion? Once we define it, we see how big it is, where it is, and how is influencing that patient and that person's life. And this is the role of recovery and rehabilitation. That's where probably we are going to. Nowadays, as you may know, neuroimaging has taken the advent. And this has been also a very recent argument. I understand last fall you had this very nice introductory question, which I think is really the point where we are at. Is neuropsychology, the way we have been studying it or heard about it, still, or does it still have a place for as it used to be? My personal view is that probably we are at a very crucial point where neuropsychology is still very important from an objective standpoint to measure psychometrically in research what you are looking at and to see how performance is related to brain. But from a clinical standpoint, when you see the patient one by one, and you have to give them the diagnosis and you have to explain what's wrong with this brain or her brain, then probably neuropsychology, the early way neuropsychology, is not as useful as it used to be many years ago. We can perform different other diagnostic techniques. For sure, cognitive rehabilitation is a challenge, and for sure this is where neuropsychology has to help us in many ways. Whatever whichever test we use, and no matter how we know and what we know about neuropsychology and clinical neuropsychology, we should keep in mind that We need to know about clinical neurology, neuropathology, clinical neuroanatomy, which we do very well, of course. But we have to know also some about brain development. How is the brain developing in the normal situation and in abnormal or anomalous situations, which are many. The neurobiology of brain recovery, many other things. And first of all, how to evaluate the brain in vivo, which is the most difficult part of our field and our experience. If you do want to be a neuropsychologist, if you like to learn about neuropsychology, the most challenging point is that whatever we do it and we ask the patient to perform in a very narrow, in vitro, small environment, which does not, many of the times, does not extend the experience to the external environment, to the real life. This is one of the most challenging things that we have to face in these years. Next years. Cognitive rehabilitation, as you probably know, has been applied more in traumatic brain injury than any other discipline, and then amnesia and so forth, and now is also being considered in a degenerative process like dementia and Alzheimer, which is not very easy to understand by definition. Rehabilitate means going together as you were. So going back to your performance, which is impossible in a very degenerative disease like dementia. However, there's still space if we knew some of the disciplines or the arguments that we were saying before, and we have some knowledge about the recovery, about neurobiology of learning, and so forth. Having said that, the structure that is most important for rehabilitation and for learning is hippocampus, that you're studying very well. So the hippocampus is the main station to understand what can happen and what we desire and how we can explain what will happen during the rehabilitation process or after a long training period in general. So we hope that the hippocampus is working, because otherwise there's no way the patient can learn anything, even with our skills, very good skills. This is to remind you briefly about what Marcel Meslam was writing a few years ago about the 5 neurocognitive networks which are anatomically distinct one from the other, and each of these networks has a specific side of the brain, maybe, where you can we can make a difference between the spatial awareness system. I don't say more because of time, which could be, in relatively speaking, more localized in the right hemisphere with the main hubs in the frontal parietal cingulum, but basically the major syndrome which relates to spatial awareness disturbances could be considered the neglect, or the language that you know so much about, and the explicit memory, with in some respect this will help us today, or the declarative memory system, which has to do with as a major hubs, the hippocampus, amygdala, and fornix that you have heard during this week, and I have heard again during this week's. And the 4th system is the face recognition, and the 5th, which is the one that we are a little bit more addressing today, is the working memory network and the executive functions network, which will bring us directly to understanding a little bit more about how the frontal lobes are working, are functioning, if they are functioning. One thing that I like to share with you is the definition of working memory process or network. Is that system that prolongs the sensory event beyond the stimulus duration. That's what the working memory means. Prolongs the neural responses to the stimulus, dilates the cognitive elaboration of any event. This is what the memory or the working memory means. transforms sequential information coming inside your brain in a coherent, univocal, and convergent experience, which is a lot of things if you just think about it. So the role of the prefrontal cortex, which we will address because will help us to understand about the test, the California verbal learning test that we will talk about in a few minutes. First of all, please consider that up to 20 years ago, the frontal lobes were still considered like a silent cortex. 1/3 of the entire brain still considered like a silent because it did not allow thorough investigation. There were not instruments which were very easily giving us information about how the frontal lobes were working. There are many things we can say, but please again never forget how important the consideration of experience and the developmental process which will bring you to the full maturation of the prefrontal cortex. In other words, when you deal with anyone at an even age, of course you have different things that you have to consider. And if you talk to someone who is already an adult, or is a young adult, or is a senior, of course you are not dealing with that specific matured already prefrontal cortex. You have to learn more about how did the process happen, occurred little by little. In other words, there are many factors which influence the development, morphologic, embryologic, and synaptogenic mechanisms, which we don't go into it, but anyway, these are many factors which influence how the frontal cortex at the end will reach its full maturation. Briefly, again, when we talk about the frontal lobe damage, there are many ways we can address the issue. One way I like to share with you is a simple taxonomy. We can deal with developmental disturbances of the frontal lobes. Mainly, is it prototypical disturbance ADHD, or autism, or schizophrenia and psychotic behavior disturbances. We can look at the frontal lobe damage in a different way, divide them up between focal damage and diffuse damage. The focal damage, the prototypical problem would be the vascular problem, which is more focal. It will take away most part of the knowledge of any specific area. So it's a focal damage which takes away almost everything of that function, like aphasia, like neglect, or could be also tumoral or infectious disease. In diffuse damage of the frontal lobe, diffuse traumatic brain injury, for example, is the prototypical injury, which in that way you take away bits and pieces of many functions. It's just the opposite of the focal injury. You see. This will change the symptoms, will change your approach with that patient, will change also the rehabilitation effort, if we consider that. So there are different ways we can look at the frontal lobes, of course. There is also the degenerative aspect to consider. When we get older, after a certain age, of course, prefrontal cortex, the damage of the prefrontal cortex will show itself with, manifest itself with different other disturbances, and which are many times different, completely different from a young prefrontal cortex or a young mature prefrontal cortex. The dynamics are different. The way we investigate the disturbances is different. This to tell you now that we can divide it up. We can make taxonomies, how we can subdivide the prefrontal cortex in many ways, and you have already, I've heard with you last week, about all the contribution of any single area and any single network, any single aspect of the frontal lobe. In general, generally speaking, from a pathological standpoint, from a symptomatological, so from a clinical standpoint, we can say that there are some indifferent clinical syndromes. Briefly, most of the times we are informed, we are more prepared, so to speak, we know more, we read more about the dorsolateral deconvexity damage, where we see perseverative behavior, mental rigidity. We deal less from a clinical standpoint with what happens when the frontal lobe syndrome is of a ventromedial, so it's more medial injury, where we see different kind of disturbances, not necessarily or easily assessed, like the first one, the dorsolateral frontal damage. So we have to do with reduced initiation, psychomotor inertia, you see emotional ability, aggressiveness. There are scales, but not tests or neuropsych tests, which will give us objective evidence of that kind of damage. Or even worse, when we deal with orbitofrontal or inferior damage, which in this case we have to face disinhibited or disinhibition, disinhibited behavior, lack of control from the patient. And most of these patients, I can guarantee you, you can do 2 or 3 days of testing, neuropsych testing, and you don't see almost nothing. It's very seldom when you find some relevant information, objective information of using neuropsych batteries, even 2 or 3 days neuropsych batteries. So we have to reformulate in some ways our knowledge. And Alfredo Ardila was helpful a few years ago because he was pointing on the importance of the limbic and reticular activating system, which is the first stage for information should be processed by the brain, and then, of course, the receiving, processing, and storing information with the help of the temporal and posturolandic areas. In any way, we can subdivide, he says, the executive function system in 2 fundamental subtypes. One is more related to the dorsolateral prefrontal cortex, the metacognitive executive functions that have to do with the problem solving, with planning, rigidity, controlled attention, and the other one more with the orbitofrontal medial frontal cortex, which have to do with the more behavioral, instinctual, emotional expression of our general behavior. So you see, there are ways, different ways to consider executive functions. My reappraisal, my reformulating of all these things, if it can help you, could be this picture. There are psychomotor disturbances, cognitive, which is the one we know more, disturbances following frontal damage, more related to dorsal convexity damage. There are more behavioral emotional disturbances, more related to damage of the orbital inferior cortex. And there are also more ethical or moral ethical disturbances, which we find sometimes with the frontal polar cortex, if this could be researched more and more. I make this slide for you if you like to divide them up, all the disturbances. If you look at the psychomotor disturbances, we have to do with initiation, motivation, the drive, which give us the need, the urge to do something. The inhibition of the prepotent responses, anticipation, temporal integration. You see, of course, when we go into the cognitive aspect, we are more familiar with these words, abstract reasoning, problem solving, mental flexibility, which are also easier to test, to objectivize with our instruments, with the available instruments. it is more difficult to objectivize something with the behavioral emotional disturbances and self-regulation, impulse control, personality modulation. You see the words themselves. Each of these words is a specific word which relates to some networks, to some circuit, to some contribution of the frontal lobe. But it's more difficult sometimes to really appreciate and objectivize in terms of performance. Even worse or even more difficult when we refer to the ethical and social aspect of frontal lobe functioning and the social integration and so forth. So when we have, we go deep into the topic of today, when we have a battery, let's say, a neuropsychological battery, this is the one I try to use because we don't have time most of the time, so we have only residual time in our clinical activity, and so I try to use the best, as best as I can, the instrument, the test instruments, which will give me more information. And one thing here that I learned from Edith Kaplan was that no matter what you are using, you do have a score at the end, she says. You do have a score and you do formulate an hypothesis. However, if you look at the same score and how the person, the patient, obtained that score, you will find out very easily that there is a qualitative process that has gone being, adopted, and going into the qualitative aspect of performance. This will help you more than anything else to understand that patient. That's what she was saying. It's the same thing that you use when we talk about disconnection syndrome. We have the same disturbance, but not because the same area is damaged, but because different areas are damaged, they are disconnected, just disconnected from one point to the other. So, and learning more about the process and the way you achieve a result, you obtain a performance, you obtain a score, it's very important. Of course, never say that there are many tests that we can use, but this is not the reason why we're here or the object of the discussion. One of the best instruments is the raised complex figure. How many of you are used with these tests I'm talking about? Not so many, probably? Okay, that's a good portion. The complex figure deserves probably another seminar sometimes, because there is a very interesting test instrument. It has a qualitative, objective score, but behind that score there are many strategies adopted, and there are many qualitative aspects of performance that we can generate and we can grasp. The other one, that's the reason why we're here. Don't worry, some words are in Italian, but don't worry. This is just to show you how the format is. These are bits and pieces. We have a first part of the test. We will see it in the next few minutes. And there are 16 words which are which the examiner says 1.5 seconds at a time, so 16 words, but you don't say it to the patient that they are going to be 16 words. This is a learning test, that's what you say. We will pretend to go to the market and you have to buy, remember, to buy all these items. I'm going to say you a list of words, please stay, be careful, without distraction, try to learn all these words and tell me back as soon as I finish all the words that you recall, no matter the order of presentation. That's the, basically what we say. So these are the words. By the way, the words are selected after, or have been selected after a preliminary work of and we personally did the same with the Italians, 375 subjects, normal subjects, were asked, tell me the words that you remember which belong to the category of fruits, or to tools, or kitchen instruments. So they were coming up with all the, it's a fluency, category fluency basically. So at that point we took away the most prototypical answers. So if I ask you, tell me all the fruits that you can generate, that you know, you end up saying apple, banana, pear, and then the rest. So easily in a learning test, a verbal learning test, if I take those words in the list, if I put the words in the list, it ends up that you remember later the word, but not because episodically you have learned that word, but because you semantically come up with the same word. So
Frequency effect.
Yeah. No, it's not. So it's a prototypical. So it's a prototypical of that category. So you make sure that you take away the prototypical items. And then you end up with all the words which are very frequent, still frequent, of different length. So with the phonological complexity, with syntactical complexity. Anyway, this is exactly as it was done by Edith Kaplan and Dean Dallis many years ago. And we created the Italian version, which we administered to more than 1,000 people, normal people, around the Italian territory. So this is the, the 16 words. Here you have a scoring chart. We will see it now later. So this is the second list that you give only once after the 5 trial of learning as an interference or as an interfering list. And then you have the last part, which is the recognition list. That, in this case, you tell the patient, now at the end, I'm going to read you a list of items that you can find at the supermarket. Don't worry, you only need to tell me if you think that that word belongs to the first list, the Monday list, so the list that we have done several times. And you say no if you don't think that that word was belonging to the learning list that we made on Monday. This is in general the test. Also, remember that at that time, the only instrument available, we're talking about early 1980s, at that time, the only instrument was the Ray Auditory Verbal Learning, which was made as well of 5 items, 5 learning trials, with 15 items, non-related to each other. It was a little bit more, it was different. So non-related was just episodic memory, okay? And they also had a interference list, and there was nothing else. There was no recognition. Now the recognition was placed in this test afterwards, after almost 20 years, after the California Verbal Learning was distributed and known everywhere. And this is the recognition test for the ADLT, where, as you can see, it's not a listening a word and say yes or no, like in the California, but you see you see a brief paragraph and try to underline which word you think was in the list. It was a different approach, and it's a different material, and it's a different administration way. This, which looks like silly difference, actually is a very important difference. It's a different thing that hearing a word and saying, yes, I've heard the word or not. It's a different thing than reading the word and underlining, if you remember, if you recall that word from previous learning. So this is the test that we knew at that time. This is Edith Kaplan. This is the phrenology card that she sent me. She was trying to apologize because I didn't receive some material from her, but she was in San Diego already, because Nelson Butters was staying very, he was very sick. He was with amyotrophic lateral sclerosis, so she was explaining why she could not be with me at that time. But anyway, those years, 1983, 84, she was developing together with Dean Dallis, Joel Kramer, and Ober. She was developing the California Verbal Learning Test. Now, what does the California Verbal Learning Test? Now I use Catania Verbal Learning Test, which is the city where I come from. There are several parameters, there are several aspects which are important. We do have a learning curve, as any verbal learning test. Verbal learning means I give you something, a list of words, and I repeat a few times, so you have the opportunity to learn the list. Okay, and we do have the learning curve. But we do also have the chance to look at semantic clustering, which means since the words belonging to the list of the California are categorized, now you will see it, there are 16 words belonging to 4 different categories. The animals, or fish, or clothing, or tools, you see. So you don't say to the patient, let's go shopping, you say, on Monday, and you say a list of 16 words, but you don't say, no, be careful, there are words related or pertaining to different categories. So you don't say that. So the patient has to figure that out by itself. So semantic clustering allows you the opportunity to clusterize once you understand that there is a better process to learn, then you use it automatically, intrinsically, you use that strategy, which is a strategy, a semantic strategy, to look, so you have the learning curve made of how many words you remember during the 5 learning trials, and you also have another curve, which is the semantic clustering. So how many clusters, how many words you say following another one, the previous one, belonging to the same category. If I have fish, and you say salmon, and then you say mackerel, so to speak, that makes a cluster. So in a unrelated words like a VLT test, this will never happen. With the California Verbal Learning, you do have the chance to look at semantic strategy. So you use a strategy, and we later will figure out where and why and how to make the strategy. We also have the interference. Interference is generated by the list that you learn for 5 times, the Monday list. When you give the second list as an interference, of course, you tend to forget the previous list, the list that you have acquired already in 5 learning trials. And here you have one more point which discriminates. It's a new aspect. You have a proactive and a retroactive interference, which means if I ask you to learn that list and I give you the list for 5 times, then you learn the words with your best, or the best as you can. But then when I give you the second list, the first list will interfere on the second one. It's a proactive interference. But when I give you the second list, which is called the Tuesday list, and then later on, after a few seconds or in a few minutes, I tell you, do you recall, by the way, the words belonging to the Monday list? That's a retroactive interference that the second list makes on the first one, you see. So you tend to recall the second list, but not the items of the first one. And these are also aspects that, and you can easily understand, are of a frontal kind of generation, generated by frontal disturbances, which is an interference process. So we look at strategic learning, and we look at cued learning. We will show you then why or what we mean. Short-term recall, free recall. Because once I ask you, do you recall the words that I just presented you several times in the Monday list? And you try to recall the words. This is a free recall. And after you make your performance, then I give you the hint, which is a frame that I give you. I give you a cue. It's a cute recall. By the way, some of those words, you know, were they clothing. Do you remember the words? So you are providing them with some hint. So at that point, if you freely recall not so many words, with the cue, you recall more words. So that's another look, it's another expedient we use to investigate learning and retrieval. And then you go, after 20 minutes of the learning trial and the interference list, and then the short-term recall, you have 20 minutes delay, which you make sure don't use, for those of you who use the California Verbal Learning, never use verbal instruments, because otherwise you interfere more and more on the testing. So you have to use visual spatial testing. We use the raised complex figure most of the time, so there's no interference or further interference. And then we finally look at the recognition. I'll show you what I mean. So we have anatomical contribution during learning, during clustering, the free recall, the cued recall, and the recognition. So different phases, you see, with only one test. Now, this is the original test. This is how it was made, by pencil, paper, and the ruler, and that's it. These are the words. So I give you the words. I can, let's suppose we're going shopping on Monday. I'm going to read you a list of items for you to buy. Listen carefully. When I'm through, I want you to say back as many words as you can, no matter the order, as I told you. So you give the words one by one, every 1.5 seconds. So drill, plums, and so forth. And the patient will tell you whatever recalls, and you write them down here. So the first time, then you say, I'm going to repeat the Monday's list one more time. You reassure the patient. Make sure you recall as many words as you can, no matter the order, no matter if you have already recalled them the first time, don't worry, you'll do it always better. The second time, the third time, and so 5 learning trials. Now, down here, we have the number of words which are correct. So how many of the words recalled are in the list? You have the perseverations. How many of the words that the patient recalls are perseverations? So words, same words, which are repeated more than once. How many of them are intrusions? And you know what kind of intrusions is more easily found during the learning trials? The intrusions most common are the prototypical items that I was telling you before. So they understand that there's something in the category of animals, they come up with elephant, with tiger, which are prototypical, are not in the list. And at the end, you measure also the clusters, which is how many words here in this small column, how many words that you are saying after the first one belong to the same category. So you just count how many clusters you make per each trial. Okay? It's too boring probably, little by little, but this is why we are here. So we have to go this way, piece by piece. So, California is California. Why? Because Edith Kaplan was working in Boston. So it's California Verbal Learning because she was working with Dean Dallas. While she was visiting Nelson Butters and so forth, she ended up with working this test with Dean Dallas in 1983-84, which was exactly the same time when I was in the US a long time ago. Paper and pencil, and was a quantitative and qualitative instrument of verbal learning. You see, at that time, as I told you, there was the auditory verbal learning and the Bushke-Fund. It's a different kind of test. We cannot address the issue today. The main differences, these are 16 words rather than 15, with 4 categories. There was a list B for interference with the same characteristics. You were measuring also intrusions, perseverations, cued recall, and recognition. So with the same tool, with the same instrument, we were looking at all these things. And I can guarantee, and I try to show you, that it's completely different to use the test in a normal population and in a pathological population with different pathologies. So this is the second list, the interfering list, okay, the Tuesday list. There are 16 words again, 4 categories, but 2 of the categories are shared, which means the same categories in the first list and in this list. 2 categories are not. So the question now I ask you, where is the interference more important, do you think? In the shared categories or unshared categories? Shared meaning that they're the same categories, different words, but same categories. Unshared categories which were not in the first list. So if I do measure interference, do you think the interference will apply more in the shared categories or unshared? Shared categories, because you make more interference between words of the same category. So again, here this is the scoring system. This is the short-term free recall, and you again collect the number of words, perseverations, intrusions, and clusters. Once you finish with the short-term free recall, you ask the patient, you know, by the way, some were spices and herbs. Do you remember them? Do you recall any of them? Or fruits, or clothing, or tools? So you are giving a hint. If the difference between a free recall and a cued recall is more than 4, already you are showing that there is an interesting help, anatomically speaking, by some other structure than the temporal lobe. Because you are providing the frame, you see, the qualitative aspect of performance. So the main feature, again, clustering during learning trials. This is for the first time in a verbal learning test. There's the Ebbinghaus list, the AVLT, the selective reminding test. For the first time, we have a new concept. During a learning trial or during learning trials in a learning curve, you could also look at clustering, which means the clunching and putting together words belonging to the same category, which means use of strategy, basically. It's a strategical learning. You could look at primacy and recency effect. Now we go to that point in a few seconds. Because if you, let me see, strategical learning, let's go back. And primacy and recency. Do you know what primacy and recency, the definition? It's very simple. If you try to recall the words of the list that you are learning over and over during the 5 trials, for the first time that you don't know the list at all, you try to use the best as you can, the either primacy effect, remembering the words that were in the very first part of the list, primacy, this was described by Ebbinghaus, or recency effect. So there's a U-shaped learning, basically, so you better remember these words and these words of the last part of the list, but not in the middle one, okay? So this is the primacy and the recency effect. And this will happen for any learning list where there is there are non-related words, like the AVLT, because there is no other way to go around. You have to go either by primacy, recency, but then over and over you recall more words as you go ahead. But in this, with this instrument, in the first trial and in the second trial, you could see, now I will show you some examples, of the primacy or the recency effect. But a normal subject, by the 3rd time, the 3rd learning trial, that you hear the same words again, immediately, if you are a normal subject, will end up having from a 5 or 6 or 7 correct items, immediately 12, because you clench the words semantically with this cluster. So you understand that there's a strategy, I mean, you can use a strategy because you understand there's a way to do a better performance. So that's what happens. So you go from a primacy recency effect to a clustering strategy effect with the same instrument. So you can measure the clustering during learning trials, the primacy versus recency effect during the first 2 trials. From the 3rd trial and over, you will look at strategic clustering. You have proactive interference, as I told you, which generates or generated by list A on list B, and retroactive interference from list B on list A. You can also look at release from interference, usually for the unshared categories. If you do have interference, when in the second list the categories are not present in the first and in the one, they are non-shared, unshared, then you remember more words of those categories rather than those belonging to the same categories in the first and in the second list. So the more you hear words from the same category, more interference you have generated inside your head. And you look at, for the first time, to recognition, which is a matching process, simple matching process. At that time, there were studies to look at delayed non-matching sample, which is I show you something, then I show you the item that I showed you before, and a different one. And you ask, which one is the newest? Which one is new item? It's delayed non-matching. Here is a matching paradigm, which is, have you heard this word first, yes or no? Just yes or no. So there are also some qualitative aspects of recognition, because you will see now the list. You can get confused because of phonological similarities or semantic similarities belonging to the same category, or list similarities, the first list and the second list. Going into details, I understand I can also bore you so much. Anyway, anatomical correlations. So we have a learning aspect versus a recall. 2 different things. Learning, you have to learn. As many times I say the same words, you learn, and you go up with your ability to learn words. Do you see that? Can you see from there? So you start with 5 or 6 words in the first trial, and then you go to 7 or 8, and then you end up, you understand there is a strategy, you go a little bit further, and then you even reach the top. And then you have a regression, a linear regression to the mean. So although you have done the best in the 4th trial, you lose something once you try to do as good as before, because for some reason you do some perseverations. It's another qualitative aspect that you can see on testing. But anyway, this is the learning curve that you have. The best performance, if this is clustering, is that you don't have clustering here, but then look at the clustering. This is a normal subject. So you understand that there is a better way to learn, and your recall is excellent. So it's paralleling the learning curve in a normal situation, in a normal patient. In somebody who has problems, you never have a learning strategy or strategical approach. You see the delta, you see the difference. It's very dramatic to see in pathology of any kind, but in certain situations more and more. So you have the learning versus recall. So learning and then recall, retrieval of the words that you have learned. It's a different process, okay? You might have a good learning with great effort, but you can have a good learning, but retrieval can be defective anyway. Because the retrieval process is the ability for each of us to go back in what we have learned, and it's not easy to retrieve all those information that we have put inside our brain with the help of the temporal lobe. We look at also attention versus memory, because attention means less interference. If you are not having interference, your memory is doing well, means you get better scores. If you have interference, proactive interference, so one list is generating interference upon the other, then you have also a significant, important impairment, so to speak, in the learning process, in the memory process. We also look at free recall versus cued recall. So freely recall what you recall without help, and cued recall what you recall with the help that I give you. Learning versus recognition, so when we use the matching. So according to what we are saying, you may end up with 8 or at the 5th trial with, let's say, 8 or 9 words out of 16. Okay? And this is possible. You do the second list, and then all, what we are saying, the short free recall, the long-term free recall, and in recognition, you still end up with 15 or 16 words. So learning during the learning trial is defective, is deficient, but recognition is fine. That's what happens most of the times. You have 16, 15 in recognition. Most traumatic brain injuries, multiple sclerosis patients, although they have problems with learning and with memory during the learning trial, at the learning phase, they do end up with a perfect recognition score. How is that possible? Because information is coming in some ways it's elaborated, it's sent somewhere else. But when it comes time to retrieve the information in the terms of matching, just a simple task. Have you heard this word, yes or no? So you have trouble retrieving, freely retrieving information, but when it's a matter of matching the word, you're okay, because you know that you have heard that word. That's it, that's only what we ask during the recognition phase. So you have a learning problem, but you do have a good or perfect recognition, which makes you the difference between the more frontal involvement and the more temporal involvement. If you have more temporal lobe involvement, recognition is defective as well as learning. If we have more frontal damage, recognition is almost normal compared to the learning curve. We will see now some examples which give you the idea. So you see the difference between temporal and frontal, I'm saying, and also episodic versus semantic. Learning words, it's episodic learning, procedural. You know the Tolving taxonomy, so it's a procedural memory, episodic memory. Semantic means that you cluster them together, so you add one more, qualitatively speaking, one more. So you look at episodic and semantic as well, with the same instrument again. And you also look at intrusions versus perseverations. Perseverations usually occur during the learning phase of the learning trials. Intrusions afterwards, during the retrieval, during the recall phase, in the second and the third part. This is the same instrument that Edith developed, and here she also added one more thing. You see the short delay, it's not me. The short delay and the long delay. So once you recall the word drill, so to speak, for the first, the second, the third, the fourth, and the fifth trial, okay? It may happen that in the short delay or in the long delay, you don't recall the same words. So she wants to see the consistent learning and recall ability for the words, each of them. So it was one more qualitative feature that she wanted to look at. And this is for you to recall again, that during the memorization or the learning phase, the contribution of the frontal lobes are many, of course. This, to summarize a few, I would say, during the encoding, it's controlling the attention. The attentional phase is reducing interference. Somebody who is in coma or is sleeping, of course, cannot learn. Cannot learn not because he's not working the temporal lobe, because there is no enough information, attentive or attentional information coming from the reticular activating system. During the manipulation, it's also helping you maintaining the information in the storage, because it will help you find a way, an easier way, or a clustering in this case, to help you and to associate items one with the other. And during the retrieval phase, is also helping you scanning in the places where you stored the information. So there are several interventions from the frontal lobe during the learning trials. But we know that most of all is made by the hippocampus and the anterior part of the hippocampus, especially with the help of amygdala. The help of amygdala, we are all experts in this, but amygdala, in my way, is here helping you the learning process when there is some more pregnancy in terms of some more semantic and volitional and emotional contribution that you like to learn for yourself. There is some more importance that you give to the information that you are trying to learn. Of course, this is a learning instrument without so much emotional involvement anyway. So let's go then to this point. So during the encoding phase, the first phase, you're trying to learn. It's called encoding phase. We do this all the time. Whatever you try to learn in a lecture presentation, in a book, in an article, if you go to the movie, in our life. During the encoding phase, we need, especially in this case for verbal information, the left hippocampus. We are not like the rats. You read lots of information and literature in learning processes in the rats. Of course, it's not our brain. Our brain is a little bit different, if you allow that. So during the encoding phase, mostly on the left for verbal information, there are some interference, attentional processes that you have to, of course, domain, and then the reticular activating system and the orbitofrontal area, which help you to stay concentrated, to be less disinhibited, to have less interference from whatever is going on around you. So these are the preliminary stage, the preliminary setting of environmental situation in order to learn. You have the manipulation, organizational phase, which is the second one, purely temporal on the left for verbal information, and the semantic organization or clustering from the frontal. You see how frontal and temporal join and work together in the process. And during the retrieving phase or the recall phase, it's a bilateral contribution, and most people agree that, first of all, it's the right side of the brain, the right frontal, which will help you regardless of the material, of the information, which is verbal or non-verbal, doesn't really matter. It's the right frontal lobe which trigger the scanning and the retrieval process, and then in this case with the help of the left frontal lobe. So right frontal activity helps the left temporal areas to find the items that you are asking. And in the recognition, it's just a matching, that's it, as this information passed through the hippocampus. Yes or no? Oh, that's it. That's the only thing we have to say. We look, and we have been, the California verbal learning has been used in many different pathologies, but not so many. First of all, it was developed for traumatic brain injury. In 1982, 83, 84, the pathology of very big interest worldwide was traumatic brain injury. There were not the rules that are now here. I don't want to make a small lecture on TBI, but anyway, TBI, traumatic brain injury, was the pathology or the best example to study and to look for this kind of instrument, which came out in the literature, by the way, in 1987. So it was originated, was developed, was used throughout the country, in the US for a few years, but it came out in 1987. Then is now used in multiple sclerosis, in stroke, during aging. You also need to know that there are several forms. There is a short version with 12 items, which are for aging. So 3 categories, 12 items. There is another shorter version for dementia, with 9 words only. There is a version for children, and there is a version with pictorial CDLT, which is interesting, intriguing, nice for you to use if you like in your research. And there you see the contribution between the left and the right. It's pictorial, so words, but objects in this case, so through the visual system. It's a nice, interesting, stimulating objective that we can have. Edith itself, herself, tried to make with the help of Lorraine Nobler, tried to make, and Biber made a pictorial visual learning instrument, but never ended up with the instrument in the literature. So, recognition is the least difficult parameter of the test. Cued recall is also as well in the hierarchy, in the top down, is easier. Long-term free recall. Why do you say? Why I say long-term free recall? Because free recall is usually very difficult after 20 minutes of something else. Okay, and you know why? Because of the semantic strategy that you used. If you understood that there was a better way to perform, you stored not just the episodic words, but the strategy inside your brain. And so after 20 minutes, when I ask you, can you tell me those words again? Do you remember those words belonging to the first list of the Monday list? The subjects immediately say, oh yeah, there were the clothing, so then vest, slacks, and then there were fish, and there were, so even 20 minutes later, you recall items even better than in the short free recall phase. And that's something that you never see with any other instrument, which tells you again that the frontal lobe is helping you generating and retrieving information due to the clustering of the semantic category. Finish.
1 minute.
3
minutes.
3 minutes. That's correct. So then, this is not important. I had some cases, this very nice case of a photographer. I skipped the history anyway. Traumatic brain injury, very important injury. This is the complex figure, raised complex figure. It was a traumatic. This is the PET scan. The right side more involved. He was depressed. This is Wisconsin, and this is the California. So this is the California, not in a normal subject, in a traumatic brain injury subject, otherwise doing perfectly. So there was no learning curve, as you can see. There was no clustering. No matter the Italian, it doesn't matter. No clustering ability. And he was using mostly a recency strategy. When you see a recency strategy, it means that you're dealing with a really or a true amnesic patient. Otherwise, we have the opposite. And there's another case. This is my rudimental trial with this case. This is a photographer. You see the injury. There's also some involvement of the left, but it's mostly right temporal. This is a good callosum, and I didn't find the onsonate on the right side. This other case, right side. This is a woman. Very good learning. Not very good clustering, although at the very end she did quite well, as you can see. And she did, even 3 years later, still okay, but not in an excellent way. But you see, she's not using, in the first 2 trials, any primacy or recency effect. She was not an amnesic patient. To say someone is an amnesic patient with the California, you can look at the primacy and recency effect, as I was telling you. This is the Ray complex figure, 3 years later. This is the damage on the right, mostly on the right. So she's doing very well, and the female sex, of course, makes the difference, because she's much better than the other one. This is the, okay. These are a few other cases. This is a dementia patient. You see the difference. There's nothing. Recognition was okay. That's also interesting. This was a primacy, I mean a recency effect in another amnesic, traumatic brain injury, amnesic patient, you see. This is another one with the traumatic brain injury, but a different one with the mesial damage, still no clustering at all. This is another one, skip that, another one, traumatic brain injury, very badly traumatic brain injury, young lady with the right side involvement with the craniotomy and so forth. She was supposed to be very good in some ways, but damage is not focal, as I told you. Traumatic brain injury is diffuse. In some ways, you also have the involvement of the other side. So you have a flat learning curve, basically, and not very well, not good clustering at all. Anyway, although she was supposed to be okay, so the clustering a bit. So it's like if she was doing the best as she could, she learned up to 10 out of 16 words, but in a very bad way, qualitatively. This is another example for multiple sclerosis. A good learning curve, but clustering again, not very good. Not as bad as in trauma, but multiple sclerosis has the same pattern of performance. This is a study that we conducted on MS patients. In yellow, you see where the difference was significant. And you see that the clusters, the separations, and the clusters in free recall were those items where you could see the difference in confrontation with the normal people. Then I finished. These are the other, just to say that this was my tribute to Edith Kaplan, and this is the check that she gave me with best wishes when we met a long time ago. That's it.
We've got 5 minutes, 7 minutes for questions.